Diagnostic Center, I welcome you all for the VDC education webinar of today's. These webinars we are having on regular interval as a part of clinico-radiological interaction, where clinicians and radiologists come together and discuss the topic for mutual understanding of the subject and for increasing and enhancement of each other's knowledge for better patient diagnosis, management, and care. So continuing the webinar series, today's topic for discussion is the imaging spectrum of cartilage bone tumors from benign to malignant. And it is truly my privilege and honor to introduce the distinguished panelist member for discussing the topic today. Our first panelist is Dr. Akshay Shetty, sir, who is a senior orthopedician located in Bengaluru. Welcome, sir. And our second panelist is Dr. S. Niharika, madam. She is a consultant radiologist in Vijaya Diagnostic Center in Bengaluru. Welcome, madam. To introduce our panelists to the audience, Dr. Akshay Shetty, sir, is a senior orthopedician in Bengaluru. Sir has done his MBBS from Shivamoga Institute of Medical Sciences, Shimoga, and has done his MS Orthopaedics from the esteemed PGI Chandigarh, and has a DNB in Orthopaedics also. Sir has done many fellowships, which are fellowship in joint replacement, fellowship in Arthroscopy and sports medicine, fellowship in robotic surgery from Germany. Sir's expertise include arthroscopy and sports injuries in knee and shoulder, arthroplasty in hip, knee, and shoulder, trauma including complex pelvic and acetabular injuries, deformity correction and Elizarov, revision arthroplasty in arthroscopy, and many more. Sir has multiple publications on his name and also is an author for chapter in orthopedic books, few of which are Orthobiologics under the topic the role of patches in large irreparable cuff tears. Other textbook is Gopalan's evidence-based orthopedic principle under the topic angioembolization in orthopedic surgery. Sir has attended various seminars and live workshops and has a vast clinical experience of almost a decade. Currently, sir is based in Bangalore as a senior orthopedic consultant in Wellness Champion Hospital in Sarjapur Road, Bengaluru, and also has their own center, which is under the name Dr. Shetty's Center of Orthopaedics in HSR Layout, Bengaluru. On behalf of Vijaya Diagnostic, I welcome you again, sir, and thank you for taking your precious time out and joining our session. Thank you, sir.
Thank you for this warm invitation. Hello, everyone over there. So, as sir has introduced me to this webinar, so this is Dr. Akshay Shetty, and I'm practicing in HSR layout of Bengaluru. So, it is very glad to be in this webinar, and I'm very grateful to all Vijaya Diagnostic guys and all your respected sirs for inviting me to this webinar. Yes, coming to this topic, this cartilage tumors. So cartilage tumors as such, like compared to other bone tumors, cartilage tumors with respect to number, it is a bit less only. But then also the most common cartilage tumors what I get to see in my office are, one thing is osteochondroma. Osteochondroma is one of the most common cartilage tumors what I get to see in my OPDs. Along with that, enchondroma. These are the two most common cartilage tumors what I encounter in my daily practice. And coming to so these are the two varieties which are usually benign, both enchondroma as well as osteochondroma. Whereas chondrosarcoma is one of the most common malignant tumors which arise out of cartilage tissue. Although the number of cases what I encounter in my OPDs with respect to chondrosarcoma is very less only, but sometimes once in a while we get to encounter these kind of cases. So if I have to talk about osteochondroma is basically I get to see in and around knee joint most commonly. Either arising out of distal femur or arising out of proximal tibia. So usual age of presentation of osteochondroma in my OPD is between 10 to 15 years. Why between 10 to 15 years? Because as age advances and up till skeletal maturity, so this osteochondroma grows in size. So that's why patients start complaining of some compression and surrounding tissue pressure related symptoms. paresthesia in and around knee region, or radiating pain down the level of knee joint up till the foot, or else some sort of fatigue symptoms because of compression on gastrocnemius muscle in case of proximal tibia osteochondroma, or else pressure symptoms on hamstring muscles, or pressure symptoms on adductor muscles in cases of osteochondroma. In cases of osteochondroma from distal femur. So this is the scenario what I get to see. So whenever I encounter this osteochondroma, first and foremost, I ask patients like whether you want to get this so get rid of this huge swelling, so for cosmetic purpose, or is it because of some pressure related symptoms, as I have mentioned. In 50% of cases, I get to hear from my patients telling that yes, we need to get rid of this for cosmetic purpose, whereas in other 50% they complain of so much of pressure related symptoms where I have to take it off. In so whenever I decide that I have to do this excision of osteochondroma, I depend on my radiologist a lot with respect to I first and foremost I get an X-ray, and after getting an X-ray, after I get a gross imaging of X-ray, then I get an MRI to see for the thickness of the cartilage cap, which actually matters a lot, because sometimes like if cartilage cap thickness is too much, then I should be suspecting of something conversion of benign tumor into malignant tumor sometimes. And also I get to see the surrounding vessels and surrounding nerves around this tumor, so that will help in surgical planning of this case. So I usually do this subperiosteal excision of this osteochondroma, so that like patient is relieved of their symptoms, and usually I get to see this osteochondroma away from the epiphyseal growth plate.
Yes, sir.
So this is about osteochondroma, which I get to see more commonly in my practice. Then Niharika ma'am has to talk about this.
Yes. Thank you, sir. Thank you very much for your clinical input, sir. It was really good hearing to you. And about the introduction of our second panelist, Dr. Niharika Gavvala, madam, who is a speaker for today. About madam, she has done her MBBS and MD from esteemed Kurnool Medical College and has cleared FRCR Part 1. She has multiple fellowships on her name, which include fellowship in MSK Radiology from Royal Orthopaedic Hospital in UK. She has other multiple modality fellowships in neuro, GI, pediatrics, stroke imaging, etc. She has received a training certificate for virtual breast imaging course, and she has received multiple awards in national conferences as well as in CMS. She has a commendation certificate from Kurnool Medical College, and she has co-authored 15 plus international peer-reviewed papers. And she's the first author for a couple of chapters in the book of second edition of Bone and Tumor-like Lesions of Bone, which is under publication under the topics radiation-induced tumors and cartilage tumors, where she is the first author for these topics, and has done various scientific presentations and poster presentations, and has professional membership in IRA, which is Indian Radiological and Imaging Association of which belongs to India, and other memberships are in European Society of Radiology, European Society of Breast Imaging, and European Society of MSK Radiology. She also had a reviewer role as she reviewed more than 23 plus articles for clinical radiology and in Journal of Arthroscopic Surgery and Sports Medicine. Truly an excellent academic career that is. So truly fortunate to introduce madam, and now you can take out the topic and you can start your presentation.
Thank you, sir. Thank you so much for the introduction.
I think slideshow we can put it on, madam. Yes. Yes. We can see your presentation, madam. I think you are muted, madam. Dr. Niharika, madam, I think you are muted. Yeah, now I think unmuted.
Am I audible, sir?
Yes, madam, we can hear you.
Yeah, good afternoon, everyone. I'm Dr. Niharika, and today my topic of presentation is navigating the spectrum of cartilage tumors from benign to malignant. Today, I'd like to predominantly stress upon the central cartilaginous tumor, which range from benign chondroma to malignant dedifferentiated chondrosarcoma. Earlier, atypical chondroma and grade 1 chondrosarcoma were considered to be two different tumors, but according to 2013 classification, it has been considered to be the same tumor, that is, it is being used interchangeably, and atypical cartilage tumors can be used, interchangeably with the grade 1 chondrosarcoma. Moving to various terminologies we use in cartilage tumors. Cartilage tumors are divided based on biological behavior, that is benign, intermediate, and the malignant, and based on histology, which is conventional, clear cell, mesenchymal, dedifferentiated, and secondary chondrosarcoma. Based on the location, it is again divided into central and peripheral cartilaginous tumors, the intramedullary ones including enchondroma, central chondrosarcoma, and the peripheral ones being osteochondroma, juxtacortical chondroma, and chondrosarcoma. Now moving to next slide. Let us discuss the one and only tumor which is epiphyseal in location and benign in nature, that is chondroblastoma. So, as a common liner for all the cartilage tumors are all characteristically T2 bright lesions with lobular contour and fibrovascular septa in majority of the cases. These tumors have characteristics ring and arc type of calcifications. So now coming to chondroblastoma, it is one and only tumor which is epiphyseal in location. It has an incomplete sclerotic rim surrounded by extensive marrow edema and chondroid matrix in a majority of the cases. It predominantly involves tibia and it is in most of the cases surrounded by a sclerotic rim. Now moving to next tumor, solitary enchondroma. So as sir said, this is one of the most common tumors which we encounter on a daily basis, and more than 50% of these tumors occur in the hand. As you can see, they are located at various locations within the digits. The most common locations being digits, humerus and femur, followed by less common sites which are tibia, fibula and the phalanges of foot. Now, how to distinguish enchondroma and the low-grade chondrosarcoma? This is one of the everyday question we encounter while we try and diagnose things. Let us have a look at it. So, we are trying to take into consideration two major things in this talk. Whole through the talk, that is the length of the tumor and the amount of industrial scalloping the tumor is causing. So, we have taken the cutoff according to an article I have referred to, that is more than 5 centimeter in length and which is causing more than 66% industrial scalloping, to be more towards chondrosarcoma. So, in case if there are any aggressive features such as cortical destruction or soft tissue mass, it is more likely to be towards the malignancy, that is higher grade tumor. And any calcifications or fatty lobules, again, they point towards benign etiology. Now, when we are able to do the things on radiograph, why to go forward with MR? Yes, MR helps us in better delineation of the contour of the tumor, the amount of edema the tumor is causing, the extent of soft tissue component, and the amount of cortical breach. Now, whether to go for contrast or not is a debatable thing. And contrast, yes, it does help. It does help. It just helps us as an add-on, but it as such cannot be the backbone for the whole diagnosis. So, what happens on contrast-enhanced studies? The cartilage tumors characteristically enhance with the proper enhancement of the fibrovascular septa with a lobulated contour. So thus it helps as an adjunct in the diagnosis of the cartilage tumor, but it as such can't be the only one on the basis of which we can diagnose the tumor. Now these are a few more examples depicting the same, that is enchondroma. You'll be surprised to know that enchondroma is an incidental finding seen in about 3% of the knee and shoulder MRs on a daily basis. Now let us see radiologically how to differentiate enchondroma and central chondrosarcoma. As you can see on the left, there is a central cartilaginous tumor which is less than 5 centimeters in size and it is causing less than 66% of scalloping. On the contrary, towards the left, there is a central cartilaginous tumor which is more than 5 centimeters in length and it is causing more than 66% endosteal scalloping, and you can even see it is causing mild cortical expansion as well. So the characteristic chondroid matrix further helps us in confirming that they are cartilaginous tumors only. So in this way, you can differentiate enchondroma and central chondrosarcoma radiographically based upon the size and the extent of scalloping the tumor is causing. Now moving to the syndromic associations, two most common syndromic associations are Rollies and Maffusi's. All ears are associated with multiple enchondromas alone, and morphosis is associated with multiple enchondromas with associated soft tissue hemangiomas. Here you can see this associated soft tissue hemangiomas. Now, the major thing to be noted is that all ears and morphosis are pre-malignant or are associated with increased risk of malignant transformation in around 5 to 25% of the cases. Now, moving to next slide. The periosteal chondroma. As the name itself suggests, it is periosteal in location with a chondroid matrix. As you can see, the lesion is periosteal in location and is causing saucer-shaped indentation over the periosteum with a chondroid matrix. So, as I have mentioned, this is lobular with T2 bright signal. Moving to osteochondroma, which is one of the most common tumors which we encounter on a daily basis. Osteochondromas are bony outgrowths which maintain medullary continuity with the parent bone. Here we can see the medullary canal is in continuity with the parent bone. The characteristic feature to say that it's an osteochondroma is the presence of the cartilage cap, which is bright on T2, and here you can see the ultrasound appearance of the same cartilage cap. So why is it important? Cartilage cap is important that cartilage cap thickness is very important to monitor the malignant transformation of osteochondroma, which is around 6 to 20%. Now moving to next slide. Now let us look at some complications caused by osteochondroma. Here we can see there is a small osteochondroma projecting from the posterior femoral surface, which is causing popliteal artery pseudoaneurysm. Now moving to next complication, which is fracture. You can see there is a cortical discontinuity with associated marrow edema, which is a fractured osteochondroma. Moving to the next complication, which is bursitis. You can see the bony outgrowth, that is osteochondroma, is causing extensive irritation of the bursa which is surrounding the osteochondroma, thereby causing bursitis. This is a syndromic association hereditary multiple exostosis where you can see osteochondromas in multiple bones. This is chondromyxoid fibroma, which is one more benign cartilaginous tumor. It is eccentric in location with a sclerotic rim and T2 hyperintense signal. This is our conventional chondrosarcoma where you can see the characteristic T2 bright signal, lobulated contour, chondrite type of matrix and the cartilage breach. Here you can see the patient was later on followed up and then the patient underwent total shoulder replacement. Now coming to clear cell chondrosarcoma. Clear cell chondrosarcoma is a great mimicker of chondroblastoma. So it is also epiphyseal in location. It has a partially sclerotic rim and it has chondroid matrix as well. So you need to follow up this case and biopsy is mandatory to diagnose this variant. Now coming to juxtacortical chondrosarcoma. So juxtacortical chondroma and juxtacortical chondrosarcoma, they look similar radiologically. So how to differentiate? The only thing which we can do is we have to rely upon the size of the tumor. If it is very large and if the calcifications are too many and there are striated calcifications, it is more likely to be juxtacortical chondrosarcoma than juxtacortical chondroma. Now let us look at a few examples. Let us see how the progression will be in case the patient presents with low-grade chondrosarcoma. Now this is an example where a 64-year-old male presented to us with a central cartilaginous tumor which came out to be a grade 1 chondrosarcoma. So this has been followed up and after 8 years this lesion has grown up in size and it has started causing some mild endosteal scalloping with a cortical breach as well. So this further emphasizes how important it is to follow up a cartilaginous tumor. So we can say that it has progressed from grade 1 to grade 3 chondrosarcoma upon follow-up 8 years later. Now let us have a look at secondary chondrosarcoma. So secondary chondrosarcoma is nothing but the pre-malignant lesions, the lesions which are having the risk of being transformed into malignant, such as enchondroma, osteochondroma, or multiple syndromic associations with enchondroma and osteochondroma getting transformed into something malignant like chondrosarcoma. So here we can see when the patient initially presented to us, he had endosteal scalloping, He had chondroid matrix. He didn't have any cortical destruction or soft tissue component. But later on, when the patient presented, the majority of the cortex has been destroyed with extensive soft tissue component. This is an example of secondary chondrosarcoma. Now, so let us come to a place where, when we are indeterminate about whether to what kind of central cartilage tumor it is, this protocol really helps us. So the radiologists from Birmingham have come up with a new tumor imaging protocol called as BACTIP, Birmingham Atypical Cartilaginous Tumor Imaging Protocol. So this only applies to CCTs of proximal humerus and knee. And the best part of it, it only takes into account two parameters. That is length of the tumor and the extent of industrial scalloping the tumor is causing. So let us dive deep into this. So the most important thing to be taken care of is it is done only on MR and it only applies to proximal humerus and knee. Moving to next slide. We'll see this with a few examples. This is a central cartilage CCT of distal femur. So this is 2.7 centimeters. So it is somewhere less than 4 centimeters. And it is not causing industrial scalloping. So according to the protocol, if the lesion size is less than 4 centimeter with no industrial scalloping, then the patient can be discharged. So let us see if this has been found to be useful or not. So the patient initially came. We found out that there was a CCT of distal femur. We have followed it after 15 months. What we have seen is the lesion has not increased in the size or any of the characteristics. So in this way, this protocol really helps us. Now moving to next slide. This is 1B, back tip 1B. The size of the lesion is less than 4 centimeters and it is causing focal industrial scalloping. So this tumor needs to be followed up in 3 years. So in case we are not sure whether which kind of cartilage tumor this is, we can just simply mention that it is back tip 1B so that helps us in management of the CCT. This is one more example. The size of the tumor is less than 4 centimeters with the tumor causing focal industrial scalloping. Now coming to back tip 1C, the size of the tumor is less than 4 centimeters and it is causing general industrial scalloping. Now coming to type 2, that is size of the tumor being more than 4 centimeters. Here the lesion is not causing any industrial scalloping, so it can be followed up in 3 years. If the same lesion is causing focal industrial scalloping, then it has to be followed up in 1 year. Now coming to type 2C, the size of the lesion is more than 4 centimeters and it is causing general industrial scalloping. So according to the protocol, in those cases where the tumor size is more than 4 centimeters with general industrial scalloping, specialist referral is needed. This is one more example where the size of the lesion is more than 4 centimeters with no industrial scalloping. Now coming to the last one, which is type 3, back tip type 3. Here the size is not the criteria. The major criteria which we take into account are the aggressive features such as extensive soft tissue component and cortical destruction. Here you can see the size of the tumor. The tumor is very large in size, that is more than 4 centimeters, but it is causing extensive cortical destruction with a soft tissue component. So this definitely needs a specialist referral. This is one more example depicting the same where the tumor is causing a cortical destruction and has a soft tissue component. Now we have discussed about the management protocol for the CCTs involving proximal humerus and knee. There is one more protocol which is only to the proximal fibula. Even this takes into account only two parameters, the length and the endosteal scalloping. Let us look at it with a few examples. Here you can see there is a proximal CCT of fibula which is less than 4 centimeters in size, but it is not causing any endosteal scalloping. So according to FACTIP, you can just discharge the patient without any follow-up. Now coming to this example, the lesion is less than 4 centimeters in size, but it is causing focal endosteal scalloping. So this comes under fact tip 1C, and based on the symptoms, it has to be managed. Now let us come to a last slide, that is what if we miss a chondrosarcoma in X-ray. So here on the left side, a chondrosarcoma was missed. So after 15 months, the patient presented to us again with severe pain. So when an MR was done, we can observe that the tumor has now progressed and caused destruction of right acetabulum. Moving to the next slide. These are just the referral articles, and all these protocols have been like validated. Retrospective validation studies have also been done, and they have been proved to be efficient in around 80% of the cases. These are the two articles which are taken into referral. Yeah, thank you.
Excellent cases, madam. And images were also very good. Both X-rays as well as MR, very good images. Thank you, madam. Dr. Akshay Shetty, sir, your comments, or you want to add anything, or you want to ask anything, any clarifications?
No, it was overall an academic piece actually. Ma'am has covered each and every topic regarding this benign and malignant cartilage tumors. So, because we get to see in OPDs only enchondroma and osteochondroma, whereas other tumors actually we encounter very rarely. So that so this has actually brushed up our knowledge also. This particular webinar and talk given by the ma'am. So I'm very grateful to that. So it was an excellent presentation, ma'am. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. Dr. Niharika, madam, one question is there for us. And any role of MR perfusion?
No, sir. Till date, there hasn't been even a single article which shows that perfusion is helpful in the diagnosis of cartilage tumors. Yeah.
Okay. For our non-radiological members who are watching this webinar, MR perfusion is just a contrast study where we give the contrast and we rapidly take the sequences of 2 to 3 seconds over a period of 3 to 5 minutes and try to see the enhancement pattern of the tumor, wash in and wash out. So that was the MR perfusion actually means. And Akshay sir, there is one question again for you from my side. When you decide to intervene in any osteochondroma or such lesions, do you prefer having a biopsy before you directly go and operate?
No, sir. Once it is confirmed in X-ray, once it is confirmed in X-ray, because osteochondroma. So once we get to know that it is osteochondroma, so only thing is like with the help of MRI, I get to see that cartilage cap thickness. That's all. And regarding other surrounding structures which are getting compressed or anything of that. Directly I go for excision, and it is a kind of excision biopsy, and that tissue is sent for biopsy later on. So in all cases of osteochondroma, I go for direct excision biopsy.
Okay, sir. Thank you much.
That is a single stage. That is a single stage procedure. I don't do it in 2 stages, particularly in osteochondroma.
Okay, sir. And sir, one more thing. In your practice, any recurrence occurs in these operated cases?
Sir, it depends on the type of osteochondroma, in the sense like whether it is multiple exostosis or single osteochondroma. In cases of single osteochondroma, usually it is a kind of we have this sessile and pedunculated osteochondroma. So pedunculated in the sense like we have a stalk of osteochondroma, whereas sessile in the sense like the broad, the base, so it doesn't have any kind of stalk. In pedunculated kind of osteochondroma, where the attachment to the native bone is very narrow through this narrow stalk, so in those kind of cases, excision is usually almost 100%. Compared to that of sessile osteochondroma, which is more common in multiple exostosis. So that's why in sessile osteochondroma, so I get to see some recurrences, whereas in pedunculated osteochondroma, which is a solitary osteochondroma, I don't get to see much of recurrences, sir. But then also, while counseling my patients in each and every case of my osteochondroma, I tell them that there are 10% chances of recurrence in pedunculated type, whereas in multiple exostosis, like I usually tell them that recurrence is around 20 to 30%.
Okay, sir. Okay. Thank you much. So I think as of now, we are not having any more questions. I think with this, I think there are no more questions. I think we will wind up. So once again, on behalf of Vijaya Diagnostic Center, I would like to thank our panelist and chief guest, Dr. Akshay Shetty sir. Thank you very much. And Dr. Niharika madam, thank you very much for joining the session.
Thank you.
And,
thank you, sir.
I would like to thank Vijaya Diagnostic for giving this opportunity to conduct the webinar, and would like to thank the digital communication team for conducting the webinar smoothly. Thank you, sir. Thank you once again. Thank you.